much has been said about the Patient Protection and Affordable Care Act. It's going to expand government control. It's going to put more people on Medicaid, increase taxes. It's not going to control healthcare costs. And, all in all, I think Vice President Joe Biden said it best. It's just going to bury the middle class. But as a young physician, what I'm interested in is how is this going to impact patients? How is this going to impact doctors? How is it going to impact the future of medicine? PPACA will increase the role of government in medicine to all new levels. Yet, as most of us in this room already know, the government is already a major player in the healthcare industry today. And in my opinion, its involvement is responsible for many of the challenges that we currently face. By expanding the role of government, PPACA will likely magnify these problems. For example, Medicare uses a physician reimbursement which is characterized by underpayments and perverse incentives. And this payment structure, in my opinion, has significant ramifications on patient care. On average, Medicare reimburses hospitals 71% of private rates and reimburses doctors 81% of private rates. As we all know, Medicaid reimbursements are much less, especially here in the great state of California. Federal government payments to healthcare professionals are so low that these healthcare professionals actually most often lose money taking care of Medicare and Medicaid patients. In 2008, a study by the AHA found that on average, Medicare paid 91 cents on the dollar for every dollar spent on a Medicare patient. And Medicaid paid 89 cents on the dollar for every dollar spent on a Medicaid patient. On average, payments from CMS are less than cost, and the amount of these underpayments are increasing and continue to increase over time. In 2000, they amounted to $3.8 billion nationally. By 2008, they had increased to $32 billion nationally. So this is a problem, and I think we have to characterize whose problem is this? Is it the hospital's problem? Is it the doctor's problem? Or is it the patient's problem? And I think the truth is probably a little bit of A, a little bit of B, a little bit of C, but ultimately the brunt of these underpayments are passed along to patients in the form of diminished access and compromised quality of care. The most commonly cited problem is the difficulty that these patients encounter trying to get care, trying to find a physician. And this problem is increasing. In 2008, MedPAC found that 30% of beneficiaries had problems finding a new PCP when they looked for one. For patients with Medicare, this translates into serious access problems. And these problems are even more pronounced for patients with Medicaid. For those patients on these government plans desperately seeking care who need it, this is a real problem. Unfortunately, I think Medicare has a much more broad, a much more complicated influence on patient access than the mere inability to find a physician. In the outpatient setting, these underpayments force providers to see more and more patients in a day to make a living. This leads to shorter visits, less doctor-patient face time, less time for patients to have their questions answered, less time for patients to be educated about their illness, to understand the treatment course, and really just be a player in the healthcare decision-making and really understand what's going on. Ultimately, these lead to compromised quality of care, not to mention dissatisfying to both the patient, but not only the patient, also to the physician. In the inpatient setting, these underpayments put tremendous pressure on hospitals, on physicians, for quick hospital discharges. Occasionally, this could come at the expense of a premature discharge, which can foster readmissions, which are now penalizable for Medicare as of a few days ago. Except for minor tweaks, PPACA does not reform this flawed reimbursement system. What does PPACA do? Kind of like what Dr. Brooks said. It offers it to more people. The law increases Medicaid eligibility to 133% of the federal poverty level. This will place 15 to 20 million more people onto Medicaid, meaning 15 to 20 million new people will be using this same flawed reimbursement system. The law also takes $716 billion out of Medicare to fund this new entitlement, meaning at the end of the day, there's going to be $716 billion less in the system to pay providers. It also establishes IPAP, a 15-member board composed of unelected, unaccountable politicians appointed by the president to enforce an upper limit on Medicare spending growth annually. And if, more likely when, spending exceeds those targets, they'll recommend cuts. Now, IPAP has a very limited scope. It can't make structural recommendations. It can't attempt to modernize this huge program. All they can really do is, you guessed it, cut provider payments. So as costs soar and the promised savings fail to materialize, it's very likely that the government will look to pay providers less and less. And as a result, PPACA will worsen the access problems for patients with Medicare and Medicaid. The law also establishes 159 new agencies, committees, programs. As a young physician, the three most concerning to me are the Patient-Centered Outcomes Research Institute, the Affordable Choices of Health Benefits Plan, and the ValueBased Payment Modifier. The mandate of the Patient-Centered Outcomes Research Institute, also known as PCORI, is to identify research priorities and to conduct research comparing the efficacy of medical and surgical interventions. Now, supporters of comparative effectiveness research believe that this research can educate patients, that it could help patients to make better clinical decisions. Now, this could foster patient education and better decisions. The potential harm depends how it's used, because it could just as easily quell medical innovation by centralizing care. Federal regulators in Washington, looking to save money, as they usually are, could easily use this research to ration care by fiscally punishing physicians prescribing, quote, less effective treatment, whatever that means. This research, coupled with reimbursement changes, could easily pave the way for the federal government telling patients the procedures, the tests, the medicines that patients can and cannot have, irrespective of willingness to pay and personal preference. Now, what this would do is it would replace the professional judgment of physicians with rigid rules set by regulators in Washington, D.C. A one-size-fits-all approach does not benefit real patients. After all, patients are individuals, not programmed robots. The problem with this approach is everybody isn't the same. In medical school, I'm sure our medical student contingency back there has probably heard the expression, patients don't always read the book. What this means is that patients can present very differently with the same illness and respond very differently to the same treatment. Physicians need flexibility to treat not the average patient, but the actual patient standing in their waiting room. Comparative effectiveness research ignores these crucial differences. It also ignores the various cultural, religious, life experiences that patients bring with them when they go to the doctor. In the end, this type of medicine will stifle choice and crush innovation. Now, to be perfectly honest and fair about the matter, the president has promised that this won't happen. But if you believe this, you also might want to take a look at today's job report. But in all, PPACA doesn't prevent this from happening either. It says, quote, not to be construed as preventing the secretary from using evidence or findings from such comparative clinical effectiveness research in determining coverage, reimbursement, or incentive program. So definitely still on the table, and let's not forget, as the president said, he will have a lot more flexibility if he has a second term. So as a young physician, another concerning part of PPACA for me is the affordable choices of health plans. This is the section that establishes exchanges where customers can buy a, quote, qualified health plan. Now, it's been well discussed how this part of the law gives the federal government unprecedented control over insurance companies, which I think without question it does. But it actually gives unprecedented control out of every single one of us in this room, assuming everyone in this room is a doctor. PPACA states that starting January 1, 2015, a qualified health plan can contract with a provider, quote, only if such provider implements such mechanisms to improve healthcare quality as the secretary may by regulation require, unquote. What this does is, depending on the guideline, it gives the federal government unprecedented new control over physicians. And not just those accepting Medicare and Medicaid, but over those accepting any third-party payer offered through the exchange, which could very likely be any third-party payer, as most, if not all, will have to compete in these exchanges come 2014 to stay in business. This will coerce physicians to practice medicine, not the way they were taught, not the way they've seen work, but the way the federal government tells them. Ultimately, this will lead to restricted access and poor quality of care. PPACA also establishes the value-based payment modifier. This will adjust doctor reimbursement based on quality of care as defined by the HHS secretary, and also cost compared to other physicians. Essentially, this creates an arbitrary cutoff of acceptable physician costs, and those physicians above this threshold will be punished. This will have the effect of disincentivizing physicians across the board. The threat of fiscal punishment will further push physicians to practice standardized care and put tremendous pressure on them to not order the tests, the consults, the procedures, the medicines that their patients need. Ultimately, this will result in compromised care. And for cash-strapped hospitals hoping to avoid the penalty, this mandate will likely degenerate into costly new layers of oversight, which, although they're designed to save money, ironically, they will be very expensive and very burdensome to implement. For physicians, this will translate into more time with executives, more meetings, more suits, more people with non-clinical background looking over, questioning every clinical decision, and less time at the bedside practicing clinical quality medicine. A severe physician shortage exists in this country. We don't have enough doctors, and we don't have enough doctors in the pipeline. According to a November 2008 report from the AAPS, by 2025, there'll be a shortage of 124,000 physicians. PPACA will exacerbate this. First off, it increases demand without really affecting supply. But most importantly, in my opinion, it's going to decrease supply, and probably pretty substantially. It could very well push some doctors to retire early, switch careers. An IBD tip poll actually looked into this very issue, and of over 1,300 physicians, they found that 65% of them polled opposed the administration's healthcare agenda, and an astonishing 45% would consider leaving medicine as a result of this agenda. Across the board, this would translate into over 300,000 physicians who might quit or stop practicing as a result of this law. A Medicus survey of 1,100 physicians reached a similar conclusion, finding that approximately 1/3 of doctors and 46% of primary care physicians would want to leave medicine as a result of this legislation. Now, obviously, not all of those polled who said they would leave will, just like a lot of the celebrities, who said they would leave if Bush got reelected. Unfortunately, I think they're still around too. But many, when faced with declining job satisfaction, less autonomy, more bureaucracy, more paperwork, I think will very seriously entertain this option. The law is also very likely to deter young people from pursuing medicine in the first place. College students only a few years younger than myself will have to think long and hard if it's worth the investment in both time and money to pursue this career. And the composition of those who do practice, who do go into medicine, will likely be a strong deviation from the status quo of the brightest, best educated, best trained, and most dedicated. A combination of fewer new physicians and an exodus of physicians in practice will create an access nightmare for patients seeking care. And ultimately, this will lead to restricted access, long waits for appointments, and rationed care. And I'm not the only young physician with these concerns. A recent Physician Foundation survey of 500 physicians under the age of 40 found that 49% of those polled believed PPACA would have a negative effect, compared to only 23% that thought it would have a positive effect. 57% of those polled were pessimistic about the future of healthcare under this agenda. We have the world's premier healthcare system. Can it be improved? Sure, of course. But I think rather than rolling the dice, rather than starting from scratch, a better approach for reform would be to build off the success of the current system. So what works? Well, competition works. Competition between companies forces these businesses to produce a better product at a cheaper cost. In the end, customers win, patients win. They get more choices and costs are held down. Competition works in the other 5/6 of the economy. It's what the other 5/6 of the economy is based on. Can it work in healthcare as well? Most certainly. It is effective in healthcare as well. Just take a look at Medicare Part D. That's the perfect demonstration product of what the potentials could be. This is the Medicare prescription drug benefit, where private companies offer plans to seniors that compete, and seniors have the ability to choose a policy tailored to their individual needs. What this has happened is choice and competition have kept costs in check. In 2011, it was predicted that the monthly premium would be $53. Instead, it's $30. The CBO predicted that the program would cost somewhere around $575 billion between 2004 and 2013. Instead, it's slated to cost $375 billion, or 32% less of the original CBO estimates. Can the success of Medicare Part D be applied to the entire Medicare program? I think so. And this is exactly what the bipartisan Medicare reform of Wyden and Ryan attempts to do. I think this, coupled with other solutions, such as tort reform, expanding health savings accounts, creating a real national market for health insurance, as well as making insurance more portable, would go a long way towards lowering costs and assuring that patients get the care that they need and want. Without question, our country is currently at a fork in the road, and one way or another, spiraling costs must be controlled. The competing solutions will take our healthcare sector, in fact, our entire country, down dramatically different paths. One approach would empower bureaucrats with not that much medical knowledge and very little knowledge of the individual situation to draw lines in the sand and make those tough decisions for patients and families. Another approach empowers patients to be smarter consumers of their lives and their healthcare dollars. To quote the president, that's what elections are for. Thank you very much.